Welcome to ElderCareNow. I'm here with my business partner, Frank Cunningham, and our special guest, Kim Acosta. And of course, I'm Steve Torres. So today, we have a special guest with us who does advocacy in healthcare. And I'm going to make a little bit of an introduction to about Kim. So Kim is a professionally registered nurse who basically found a breakdown in communication between patients, their physicians, and the healthcare team. And with the deep passion for quality patient care as her driving force, her goal became to bridge this gap to ensure continuity of care, patient safety, and best outcomes. Kim has worked in a variety of healthcare settings, caring for patients on both ends of the lifespan, infants through seniors. She began her career as a perinatal nurse with the USC Perinatal Group, focusing on maternal and fetal medicine, high-risk pregnancies, maternal complications, procedures, and coordinating referrals to other specialists. And she often worked in collaboration with the Children's Hospital of Los Angeles. From there, Kim moved on into home health care and hospice care, where she has for several years worked with patients who have multiple health concerns. It was while doing this that she felt that the driving need to pursue was advocacy. So basically, she witnessed a communication breakdown between providers, clients in their homes. She devoted much of her time communicating with providers on her behalf. So basically, she was educating her clients and family members about their health conditions, medications, and available options, thereby empowering them to take an active role as a hospice nurse. Kim considered it a blessing to be with someone as they were nearing their end of life, and in doing so, has learned that more often than not, dying is a process, not a single event. She has been honored to guide patients and family members through that journey, ensuring death with dignity. Kim earned her bachelor's in science and nursing from Azusa Pacific University, where she was a member of the Sigma Theta Tau International Society of Nursing for her academic excellence. She is currently a member of the Alliance of Professional Health Advocates, a subscriber to the Health Advocates Code of Conduct and Professional Standards, and is a proud member of the Glendora Chamber of Commerce. Kim currently is the founder and owner of Professional Healthcare Advocates. That was a lot. She's very accomplished, obviously, and we're proud to have her here with us today on ElderCareNow. So let's back up here. Break it down for us, Kim. What exactly do you do?
How much time do you have?
It's yours.
Okay, great. So I help people with navigating the healthcare system. What that means is going to be different for everybody. As far as clients, I work mainly with an older population. I do have some younger clients that might have more complex care needs, multiple comorbidities, or cancer, autoimmune disorders, et cetera. Or sometimes we're going in search for a mystery diagnosis. They haven't been able to get a diagnosis. A lot of what I do involves coordinating all of the care. I'm not acting as a traditional nurse in the sense that I'm not providing hands-on care. I'm not there to do an IV or to do wound care. I'm there to lead the charge. So some people will say, "Oh, you're like an orchestra conductor."
Quarterback.
I prefer the ringleader of the circus because that's what it feels like sometimes with our healthcare system. But I will attend doctor's appointments with my clients, making sure that we're making the best of the limited time that they have in front of a provider, making sure that the right questions are being answered, and also the value of having a nurse, a clinician there with you that speaks the language. It's really huge. It can't be understated. So I can go in, I can talk to this doctor, I can give them a really brief 2-3 minute summary of this person's health conditions, what their baseline is, what happened last month when we saw the kidney doctor or the cardiologist, what medications have been changed. Doctors respond really well to it. They appreciate it.
Well, you're speaking their language and then you're translating it to, the normal person, right?
Yes,
Okay.
yes.
Okay.
So I can both communicate to the doctor, understand what they're saying. They don't have a lot of time. They're wonderful. There's a lot of good people in healthcare. They're just overworked. They don't have the time to sit with you and spend 20 or 30 minutes that you need and deserve to talk about your diagnosis and answer your questions.
Yeah.
So in this situation, we can get through our visit and then we can sit for 20 minutes after or 30 minutes or however long it needs. Or maybe they come back with questions the next day. Good luck getting a hold of the doctor's office, try to ask another question.
Right.
So I'm there. I can be that support. I can be that resource for knowledge. A lot of times the doctors will say, come back and see me in 3 months or 6 months, get these labs done a week before, or go get this CT scan testing. I can provide care coordination for that. So I take that lab order, I put it on my calendar. They don't need to worry about it. A lot of times I can send out mobile imaging. I can send out mobile phlebotomy. Majority of my clients don't even have to go to the lab and sit at Quest or LabCorp waiting to be called in.
Really?
Especially when they're fasting labs. It's hard to get out early in the morning. I'll send providers directly to them. A lot of these services are covered by Medicare. My services are not, but I can coordinate all of these extra players. We have a whole team that we bring in.
You're an intermediary,
Yeah,
basically.
yeah, absolutely.
So, so sort of define to me, like, so who is your clientele? Are they infants to seniors, or where does the spectrum?
So when I originally started my practice, my first thought was seniors and individuals with complex care needs. I was working in home health, and that's where I really saw the need. When I originally went into home health for the flexibility of scheduling, I needed flexibility because I was going back to school to get my bachelor's in nursing. I started as an LVN, going back to school. And it was something I looked at as sort of a means to an end. And I fell in love with home health. I got the opportunity to work home health and hospice. Hospice end of life care is very near and dear to my heart. I
Was
would
that
see
because
these-
there was a personal journey there, or
Oh,
was
it's
it
huge.
just?
Like dealing with people in their homes is so much different than dealing with people in an office or in the hospital. You might see them for a few days, but you really get to know these people. You know their struggles, you know their families, you know their living situation, understand the social determinants of health, all of these things that play such a huge role. And you really become like one of their family members. They trust you to guide them
Yeah.
and to support them and help them. And you know them so much more intimately than any of their providers. And so it was really seeing this need where people would discharge home from the hospital. For example, I had a gentleman who discharged home. He had a fall. They kept him in the hospital for a couple days. They did a big workup. They couldn't figure out why he had a fall. They sent him home. I'm saying, show me all your medications. Don't just show me the list from the hospital. Show me all the bottles. Let's get them from the kitchen, from the
Right.
living room, from your bedroom, from the bathroom, everything. And we sit down and we look at them. And this patient has medications being filled at both Walgreens and CVS, blood pressure medication by the cardiologist and the primary care doctor. A lot of people can be on multiple blood pressure medications. That's not a problem.
Yeah.
But there was too many, and there was a lack of communication. And that's why he fell, because his blood pressure was so low. And he spent days and racked up thousands of dollars in healthcare bills and a huge strain on the stress of the hospitalization to the individual and the
Yeah.
family and all of this for nothing. For nothing. It yielded nothing. And then I was able to come in and in 5 minutes figure out this is exactly what happened. We've got to get everybody communicating, the providers, right? There needs to be that continuity of care. We need all the meds coming from one pharmacy so things like this don't happen.
Yeah.
So that was one of the biggest reasons why I was like, people need help. There's such a huge need for this.
I have a question.
Yeah.
Were you able to help the family in a hospice situation educationally, like what's going on here?
So that was another big one for me that I loved. I didn't know anything about hospice going into it. I worked on the other end of the age spectrum. I worked with high risk pregnancies or babies with fetal anomalies.
Uh-huh.
And originally, when I started my business, I thought maybe I would help guide those types of patients too,
Yeah.
but none of them ever came to me. So,
Change of course.
yeah.
Course
So,
correction.
but I love working with seniors. I'm super passionate about quality of care, treating people with dignity, respect, end of life, and those are the bookends of your life, your birth and your death. And I believe you mentioned it in my bio, but dying is a process
Right.
more often than not. There are people that just go to sleep and don't wake up, or there are people that drop dead of a heart attack immediately. But especially working in hospice, a lot of that is a process, and it's really hard on both the individual and the
Mhm.
family. So guiding them and letting them know what to expect. There's sort of a predictable course that we can see. We know certain things are usually going to happen in the trajectory. We don't always know the timeline, how long it's going to take, but watching somebody transition and then go into actively dying and recognizing the things, the modeling of the skin, the lack of the ability to swallow, what people call the death rattle, all of these things,
Yeah.
they're terrifying to families to watch your loved one go through this and to worry that they're suffering.
Yeah.
And that's where hospice does an amazing job, is just to educate the family, to prepare them, to treat the patient with dignity, with respect, to make sure they're comfortable. Everybody deserves that. And I take it very seriously because you don't get a do-over in somebody's end of life experience. It has to be perfect.
Yeah, and
Yep.
so I mean, you're feeling definitely a void in everybody's life. How do people find you? Where do you get your clientele from?
I would say majority of my referrals are from my existing clients or their family members. A lot of times they'll be talking to a friend or a loved one, and that person will be saying, my mom's in the hospital. They want to discharge her. I don't know what we're going to do. She's not ready to come home, or whatever the story may be. Somebody just got diagnosed with cancer, but they can't get an appointment to see this specialist for 6 weeks. And what do we do? And they say, call Kim. Kim will help you.
Mm,
And I tell everybody, just send people my way. I
yeah,
will help them, whether they end up hiring me or not, whether they need me. I will find what resources they need, or I will point them in the right direction. My goal is making sure that people have access to good quality healthcare. It is there, but you have to find it and you have to fight for it.
well, I mean,
And go
we're
ahead.
we're in the elder care business, and we deal with seniors every day, and it's like you're definitely your services are needed because there's a lot of people we deal with that have families who can sort of guide their loved one, but there's a lot of individuals that don't have family, and they're sitting in a boarding care or they're sitting in an assisted living place. How do those people find you?
So the next second source of referrals
I
is
was gonna
from,
I
yeah,
was gonna say it's placement placement people
yes.
are referring to they need a geriatric care manager. Kim's a geriatric care manager. So somebody's dying and we need some help, refer to Kim.
Got you. Okay.
Right.
Yeah, that makes
Yeah,
sense.
I work with clients in facilities. I work with clients in their home. You mentioned that some people don't have family and
Hmm.
some people don't. I'm their everything.
Yeah.
And other people do have families, and they have wonderful families that are involved, that love them, that are knowledgeable, that care about them, that have been doing a phenomenal job up until the point where they come to me.
Yeah.
But what you get, the gift that you get by hiring an advocate, is you get the gift back of that relationship. Now you could be the son. Now you could be the daughter.
Mm.
You don't have to be the caretaker. You don't have to be the one saying, did you take your medications? Are you eating properly? Are you getting to the doctor? Do this, do that, and feel like you're policing the situation. You get to go and visit and say, How are you? What did you do today? I love you. And have those wonderful times back because you bring in a professional. Also, as much as we may know, you don't know what you don't know.
Right.
So how do you know what to ask? I've seen people come to me, brilliant people that have experience working in healthcare. I actually have several clients. I've been hired by several adult children that are nurse practitioners, physicians, dentists, and doctors, all of them. And you know what? They say, I don't know how you do this because they work within that system, but they don't deal with the insurance end of it. They don't understand Medicare guidelines, the appeal system, patients' rights. It's more than just having the healthcare background. The
Yeah.
clinical background is huge. There are a lot of patient advocates, geriatric care managers, case managers, whatever you call them. They're wonderful, but you need to have a nurse. I tell people, I'll have people reach out to me. I'm also listed in several online directories. One of them, the Alliance for Professional Healthcare Advocates.
Okay.
I direct people there on a regular basis because I go by patient advocate. I have a board certification in patient advocacy, and I'm held to their standards of education, their code of ethics. And I tell people, if you don't hire me, it's fine. There's plenty of people to go around. There's not enough of us. So I'm happy. Find who you feel comfortable with. Find what fits for you, but make sure you hire a nurse
Yeah.
because you really need that clinical background. You need to understand. You need to be able to call out a doctor and say, this doesn't look right. You know, why are we doing this? You know, I've had clients that were going to be discharged from the hospital and I'm looking at their portal and I'm seeing their hemoglobin consistently dropping. Does that happen in a situation where somebody's critically ill? Absolutely. But when I'm seeing a 2-point drop, I'm like, you know what? Maybe this person has a GI bleed. We should probably check before we send them home. Something happens and they end up back in the hospital.
Sure.
Let's avoid that readmission. And I've caught it more than once to where I'm like, hey, humor me. Can I get a fecal occult blood test? Let's just check before we discharge. Okay, that's fair. Sure enough, it's positive. We've got a bleeding ulcer.
Yeah.
You know, all of these things. And part of it is I know my clients. So I know what's normal for them. I know what's not normal for them, which is huge in advocating for them. Where these providers, especially in the hospital, you don't see your family doctor in the hospital most times anymore. You have a hospitalist.
Right.
They don't know you. And how many patients are they seeing in a day? 100? How many am I seeing in a day? A few that I've been working with for years most of the time.
Yeah.
So it really makes the difference having somebody, a healthcare professional that knows you.
So before Frank gets into asking a question, when does a family or a person reach out to you for your services? Is it when they're deathly ill? Is it when they don't feel well? At what point in time?
When they're in a crisis, almost always.
Okay. So you're saying that's when they should, or
No,
or is that when they
that's
do?
when they do.
Okay.
Yes.
What do you recommend?
That's usually the case.
Yes. Most people will come to me in a crisis, and then we have to hit the ground running, which we do. Ideally, and I do have some clients who have done this. They have reached out to me and they said, you know what? I'm pretty healthy. I'm active. I still drive. You know, I've got my cardiologist. I've got my primary care doctor. I've got a few specialists, but I can manage everything. I'm not on a lot of meds. I'm good. But in the event that something happens to me and I end up in the hospital or something catastrophic happens, I want you taking the reins and coordinating my care. So I have those clients that put money on a retainer. I have all of their health information. They check in with me every so often. You know, it might be a couple times a year. Hey, I had this knee replacement surgery, or I have these updated meds, so that I know at all times kind of where we're at. So if we need to hit the ground running, we can. That is honestly ideal. One of the biggest problems is people don't even know that we exist.
Yes.
If I had
That's
$1,
that's what I was getting at.
yes. If I had $1 for every time I heard, I wish I would have known about you 2 years ago when my dad was in the hospital or my loved one was on hospice or this was going on, I'd be a very rich woman.
Yeah.
But that's the biggest thing. And that's why I appreciate this. And I thank you guys for having me here today to spread the word about advocacy and let people know that help is out there.
Well, it's really preventive medicine, isn't it?
Yes.
I mean,
100%.
yeah.
My number one goal, I tell all of my clients, my number one goal for everybody is to keep them out of the hospital.
Mm-hmm.
We want to keep them healthy. We want to keep them happy. We want to keep them as independent as possible.
What's your ideal client load?
Client load, like how many clients?
Yeah, how many at once can you handle?
Okay, so that's a good question. It always seems to work out. We've definitely grown. So I started my business September of 2020. My first 3 clients were my previous home health patients who I had been helping out of the goodness of my heart.
Yeah.
Mhm.
And I said, hey, I'm starting this business. Do you want to sign up with me? And they said, oh my gosh, yes, of course. So I was so lucky. I started with 3 people right off the bat, and it's snowballed. We're growing 30 to 40% year over year right now.
Wow.
We recently expanded into Palm Desert, Palm Springs, Coachella Valley area. I have an RN who is working out in that area, who I oversee. We collab on stuff, but she's got 35 years of nursing experience. She actually has more nursing experience than me. 35 years of nursing experience, and I have her. I have my assistant that works full time. She's not clinical, but she works in the background. She is my right hand.
Yeah.
Before having her, there's no way I could be doing what I'm doing. I have 40 some odd clients on my books
Right now?
right now. Some of them are Frank.
That's a load, man.
Well, some of them are the ones that have a retainer there
Mm-hmm.
so that we're
Okay.
ready just in case something happens.
Okay.
Some of them are clients that have been with me. For example, I have a gentleman who's younger, 60 years old. He was diagnosed with prostate cancer. He came to me and said, I don't know what to do, but I don't want to die. And I was like, fair enough.
Your prostate taken out.
I'm with you. Right. But here's the thing. So he's like, I want to see the best doctors and I want more than one opinion.
Mm.
So we go to City of Hope, we go to UCLA, and we go to USC, and
Ah.
we pick the top providers, the experts in this field. We get 3 different opinions.
Wow.
Now, cancer care is usually very algorithmic. This is first line treatment. If that fails, this is second line. But there's always these idiosyncrasies, right? So in his situation, the cancer was not just confined to the prostate. When it is, they remove the prostate and you're cured basically at that point. The cancer is gone, right?
Mm-hmm.
If it is spread beyond the prostate and it's in the lymph nodes or surrounding tissues or bone, then they don't recommend removing the prostate. They recommend more like they use these hormone blockers to kind of bottom out the testosterone. A lot of details there, but basically the treatment is different and does not involve surgery. However, in his case, he only had one little tiny bit of metastasis, one little tiny in the pelvic bone right next to it. Wasn't everywhere. It wasn't in the lymph nodes. It was just this one little thing. So what they call that is oligometastasis. It's just a very minor amount of spread,
Yeah.
right? Yeah. So in this situation, when we're doing these scans, we have these new, really wonderful technology with these scans, and they use this radio tracer that they put into your vein, and it goes through and it binds to prostate cancer cells.
Mm.
So more than likely, if we didn't have that technology, 10 or 15 years ago, they would have done the scan and they wouldn't have picked up that tiny little lesion. They would have said, oh, it's just in your prostate. We'll remove the prostate. But now the game is changing because we can pick up that tiny little lesion there. So we were probably doing surgery on people that just had tiny lesions.
Yeah.
So now there's a huge clinical trial, but it's not done yet. Results haven't been, it hasn't been resulted, right? So City of Hope is like, hey, we have this clinical trial. In your situation, you would be great for this clinical trial, and we would do surgery along with radiation within the confines of this trial.
Mm-hmm.
But you get put into one group or another, and sometimes you don't know where you're at, and this and that. So Then USC was like, we're going to do surgery. We think it makes sense to do surgery. And then UCLA was like, no, the standard is just to do the radiation and the hormone therapy and this and that. So 3 wonderful, very knowledgeable people, all of them being correct with their data, right? Because the data is not there. We don't know. It's a gray area. He did end up doing both. He's doing wonderfully. This is a really long story just to tell you that he has a couple hours left in his retainer. So he's on my books as one of those 40 clients, but he's fine. He's cured. There's nothing wrong with him. But he's like, if my cancer comes back or something happens, I want to be able to call you.
Yeah.
So I have people like that are on my list.
Well, you guided him through the other process, the other process, which what would he have done if he didn't know that existed, right?
Right.
So he got the consultations and he went with the 2 best choices and is great now, and he'll use you in the future.
And ultimately, it's his choice. I don't make any decisions for my clients. I provide all of the information so that they can make an informed decision, which is what he did.
How did you come to the inner workings of the healthcare system?
I'd say definitely home health was the exposure to kind of coordinating the care and knowing what the resources are. For example, like you learn that when somebody gets discharged from the hospital, because I'll have people call me and be like, so-and-so's, my loved one's been home for a week and nobody's been out to see them. Home health has 48 hours to get somebody out once they've accepted that referral. So somebody that knows that, if you had me, I would have been on them after 24 hours and been like, where's your person going to be here tomorrow? So those sort of things are a lot of what I picked up during home health. And then from each of my clients that I've had over the last 6 years, I learned so much. Now I feel like, gosh, I'm an expert on prostate cancer now from going through that.
Sure.
I learned so much from that experience in addition to helping do research for my client and look at different studies and compare things. I'm educating myself and I'm learning. So a lot of it is that as well.
We talked about, if you look on your website, you talk about 7 pillars.
Yeah.
Why don't you explain some of those pillars and what they actually mean? And that's basically the foundation of your organization and what you stand for and what you represent. So give us a highlight of your 7 pillars.
The pillars are kind of our services, right? And like I said, what we do for everybody is very different. So senior services is going to accompany something like I have clients say that are in their home. They have 24-hour-a-day caregivers. They come in at 8 a.m. to 8 p.m., et cetera. So every day at 8 p.m. and at 8 a.m. is shift change for several of my clients. And I get a text message from those caregivers, and I know everything that happened that day. I know what they had to eat. I know what their blood sugar was, if they had a bowel movement, what their urine looked like, their blood pressure, everything.
Yeah.
Every day, every 12 hours, I get an update on these clients because they have in-home care.
Yeah.
So I know everything. So I'm like, hey, I noticed I haven't seen a bowel movement on here for a couple days. Let me text the caregiver. Hey, did anybody forget to chart a bowel movement? No bowel movement on my shift. Okay, we need to do some Miralax because I know, and I train the caregivers who don't work for me, by the way. I don't employ them, but I do a lot of oversight.
Okay.
And I love educating them. You talked about educating. Hey, on the 3rd day with no bowel movement, stool passes through the colon, through the intestines. It gets to the colon. That's where water's absorbed. If it sits there for 3 days, all the water's been absorbed. It is hard and dry. You're at risk for a blockage. We are keeping somebody out of the hospital, maybe even from having surgery over something so little as a bowel movement, where we could just be like, hey, let's throw in some Miralax, and then everything's fine. So little things, right?
Sure.
Just somebody being aware and knowing those things. So it's a lot of that sort of thing. And then obviously, so one of my clients right now, it's hard for her to get out. She has to take medical transport. She doesn't like to get out a whole lot. It's painful. And it's stressful for her. So we bring a lot of services to her. The dentist is coming next week to reseat her crown. She came out, did a cleaning, took an impression for a tooth that was broken, and Now she's coming to get her crown. So those are types of senior services, bringing in all those care providers, care oversight, just really managing the whole thing.
Great, great.
I got a question with transition assistance here. I've never heard of this before, so I'm asking the question. Assist with a hospital discharge. What are we talking about there?
Yeah. So transitions can be any type of transition. You're talking about hospital discharge. So that can be hospital to skilled nursing. That could be hospital to acute rehab, hospital to home, hospital to assisted living, boarding care, etc. But every time there's a transition, it's a very important time, and it's a time where it's a high likelihood for mistakes to happen because you're transitioning care from one provider or one area of service to another. Balls get dropped, communication is lacking. Sometimes the meds are not there. So when my client's discharging from the hospital, I want to be there. And I want to say, before they go anywhere, let me see that medication list. Let me make sure this matches what they have at home. And what pharmacy did these go to? I want to make sure they're all waiting at the pharmacy before my patient leaves. Because once that client goes home, if you try calling the hospital and be like, hey, we didn't get a prescription for this, sorry, you're no longer a patient here. They've washed their hands of you. So I want to make sure that everything goes smooth so that they have everything they need and they don't turn around and readmit to the hospital. If they're going to skilled nursing, I want that skilled nursing facility. I want to make sure that are their meds ordered? When are they going to be here? Because I've had people discharge on a Friday night at 8:00 and there's no pain medication and they just had surgery.
Do you get involved? Just into question a little off the subject here, but
Yeah.
You're overseeing what skilled nursing facility they go to. Do you
Yeah.
have any say in that? I mean, you've got some skilled nursing facilities. It's a dump.
Oh, yeah.
I mean, so you're catching that stuff too.
Oh, yeah. So that's another thing. So a lot of times hospitals will dictate or try to dictate where the patient is going.
Right.
That's not legal. What home health company they use, what hospice they use, or what skilled nursing facility they use is 100% up to the patient and their family. They have a right to choose. Now, do they know company A from B? No. So of course they're going to listen to whoever the hospital says.
Sure.
And it's not always in their best interest, right? Sometimes it's, we just have a relationship with them. They make it easy. For whatever reason, they send them somewhere that I don't feel is appropriate. I'm going to be coordinating, and that's why you want an advocate from the very beginning. I'm going to be coordinating. Discharge planning starts at admission. So I'm talking to that case manager. They know who I am. They know that I'm looking at everything. Here's where, if we go with home health, this is the company that we would like to use. If we go with skilled nursing, this or these list of 3, we want to get them into one of these. Sometimes insurance dictates some of that, so you have to work within the confines of the network. But there's more than one place in the network. So yeah, absolutely. I'm a control freak. I want to be in charge of everything, but I need to.
Well,
That leads me to my next question.
but
Because you got
no, I was going to say that is a critical phase because where you send somebody for rehab or for whatever it may be could determine where they go in their life.
Absolutely.
So that
100%.
I do a lot of that too. With
Yeah.
helping people. I say, no, you're not going to go to that skilled nursing facility. It's a dump.
Been there. Yes.
Screen medication errors and interactions. Your doctor just prescribes blah.
And you know who picks up those errors most of the time? The pharmacist. The pharmacist will call and be like, did you know that the patient's on this and they can't take this with that? Or there's a risk of, for example, there's several medications like Zofran, which is an anti-nausea pill, Seroquel, which is a psychotropic medication used to manage agitation. Several of these medications have a side effect, and especially in conjunction with other ones, of prolonged QT interval. So basically,
QT interval?
yes.
What's that mean?
You know the heartbeat that goes like this when you're watching on an EKG? So it's PQRST. And so that QT interval gets stretched out. The heart, the electricity traveling through the heart, it gives them an irregular rhythm, right?
Okay.
But if it gets prolonged for too long, that becomes cardiac arrest.
Right.
So this is fairly common thing. Not that it happens commonly, but there's these meds are prescribed a lot that have this risk to them. So it's about knowing, does my client already have an existing heart problem? Do they
Yeah,
have
atrial
heart block?
fib or
Do they
something,
have
yeah.
AFib? Exactly. Because then I'm going to tell the doctor, you know what about this? I don't know about that. And I'm very respectful. And I'm always asking in terms of question. I'm never saying you're wrong, you're an idiot. Well, rarely. But I'm not saying you're wrong.
I love
You're
it.
an idiot, whatever. It's I was at the cardiologist with a client of mine, and she needed a new medication for blood pressure. And the nurse practitioner said, I'm going to prescribe amlodipine. And I said, she has lymphedema. Do you think that's going to make the swelling worse? Because I know that's a side effect of it. And she goes, oh, that's right. I didn't think about the swelling. So wonderful. And it's no shaming or anything like that. It's, I know my clients
Yeah.
so well.
Well, that's the whole medication management
Yes.
portion of
the
what you
big
do.
piece of it. Yes.
Yeah.
Setting up clients with making sure that their meds are managed. So sometimes I go in on a monthly basis and I fill one of these 30-day med containers with all of their meds. We can set stuff up where there's alarms that go off at 8 a.m. and 8 p.m. so that they remember to take their meds. We work with some different pill pack pharmacies where they come and it literally is like in a little plastic container and it says Monday, August 8th, 8 a.m. Then you pull that off and you take them. And the next one is Monday, August 8th, 8 p.m. You pull that off.
Wow.
Just making sure that they're safe with their medications.
That in itself is huge.
It's huge. All these things can prevent, little tiny things can turn into catastrophes, especially for older adults with multiple comorbidities that may have frailty or anything, you know?
One of
It
your
doesn't take a
pillars
lot.
is a crisis care. Let's finish up the pillars with what everybody doesn't like to talk about is the insurance and the billing.
Yeah.
Because that's something that you do help them with, right?
Right.
Okay, so what do you exactly do with that portion? Because that's the one of the most complicated things, right?
Yes, very, very much so. Yeah, if we didn't have to deal with insurance, healthcare would be a lot easier.
Do you have somebody in the office that's an expert in that?
Yes.
Okay,
So
good.
I have Jennifer, who is a dear friend of mine that's worked in the insurance industry for a long time, who I consult for these things. So as far as insurance things, there could be anything from your loved one is going to be discharged from the hospital or from skilled nursing, but you don't feel like they're ready for whatever reason. There's a medical reason they shouldn't be discharged yet, or they need more time.
Right.
I can do appeals. Medicare works with a QIO agency that you can appeal directly to. You get a response within 48 hours. And if they uphold, then they basically kibosh the discharge.
I have
Interesting.
a question
Yeah.
related to that.
Yeah.
If they don't have somebody like you,
They get
When-
discharged.
do they have a right to say no? I mean,
Yeah. So they definitely have a right, and everybody is supposed to be, this is good to know, everybody is supposed to be given what's called a NOM-NOC, a Notice of Medicare Non-Coverage, usually at the beginning of their stay at hospital or SNF, and then again at least 48 hours prior to discharge. And this explains your discharge date and what your appeal rights are. And it has a phone number for Medicare's QIO agency where you can call and file a appeal.
appeal.
But a lot of people don't know how to do that. If you're by yourself and you're sick and you
Yeah,
don't feel
sure.
good luck with that. And then even if you are like a family member, well, why are they denying it? What is the reason for it? And trying to explain that medical necessity, because this goes to a physician reviewer who reviews it. So if you can have it written by a nurse, somebody in the medical field, it's kind of going to give it a little bit more weight, or have that, make sure that it has the correct information. But everybody can appeal, and I encourage everybody to, if they feel like they're being discharged unfairly or improperly. So that's a big one, and I handle that myself And then other things like prior authorizations for medications. I can't tell you how many times doctors' offices are like, oh, it's not approved. Or the pharmacy's like, it's not approved. And I'm like, is it not approved or does it need a prior auth? Needs a prior auth. Okay, well, I've had doctor's offices, especially with like rheumatological drugs. Some of these biologics are like $10,000 a month or more. I'm really good at getting them approved, and it makes me feel good when I do it because then it's like we beat the insurance company. So I do appeals too because the doctor's offices might not have the time or they might not know. Sometimes the medical assistants, they don't know what they need to say. So I'm really good at getting medications approved for people as well, making sure they're right, and then also with billing issues, that's where we sometimes bring in Jennifer.
Wow. Well, it sounds like you're a Jane of all trades.
Yeah, no
Because
kidding.
I
you
wear
really-
many hats.
You
No
wear
kidding.
many hats and you help many people. And I hope that, today with our interview, that more people will know and understand how you can help them. I've learned a lot. I wished I knew this before, but I'll have to talk to you about that retainer, right? But just to recap, I'm not going to have you go through the whole scenario again, but tell us again how somebody would get in touch with you. Do you have a website? Do you have a Instagram? Do you give us all of your call letters of how somebody would get in touch with you?
Yeah. So I do have a website. It's proadvocacy.com.
Okay.
The name of my company is Professional Healthcare Advocates. We have an office in Glendora, so you can always Google us.
Okay. You have a phone number?
Phone number is 626-857-0000. That is my office number. I'll
Okay.
also gladly give you my cell phone number.
Sure.
Text is a wonderful way to get a hold of me too.
Okay. What is that?
626-831-1451.
Okay.
You can email me at kim@proadvocacy.com.
Good. Yeah.
And you can find me on Facebook and I think Instagram, but I'm not really good with social media. I don't keep up with it. So you're better off just calling or texting or
Great.
emailing.
Okay.
So
Good. Frank, did you have any other questions or
No, it's just-
advice that you need?
No, I've known Kim for a while, and I'm on the board of directors of Convalescent Aid Society with her.
Okay.
And she's involved in the community in that sense. She just they just did a garden party, and she was a big part of that. So she's all over the place,
That's great.
and I guess she's not quite busy enough.
I'm like a shark. I always say if I stop swimming, I'll die. I need to live at like a 10 at all times. So
Wow.
I like to stay busy. I like to have a lot of balls up in the air, and I thrive in turning chaos into order.
And your husband puts up with you?
He does. For like 20 years, he's put up with all of my craziness.
Wow.
Yeah.
You're a lucky woman.
Well, everything you do is, I believe it's well needed in our society, especially right now with our situation with our healthcare crisis. So we need somebody like you, and it was a pleasure, and we thank you for joining us today and spreading the word and sharing
you.
your knowledge with us. And hopefully, there's people out there that can use your guidance. And again, we appreciate your being here.
And thank you for allowing me to share about advocacy. And like I tell everybody, just call me. I will help you. I'll point you in the right direction. I'll get you who you need. I always do free consultations. So if you're not sure what you need or if you even need an advocate, just reach out.
Thank you very much. We appreciate that.
Thank you.
Thanks,
All right.
Kim.
Thanks, guys.
Appreciate it.
Yes.
Thank you.